So we're going to get going. So today is the 9th, which is Wednesday, if I remember correctly. Yeah, it's Wednesday. I had to think about that for a second. That's why I got the dates messed up. For some reason, I was thinking that today was Thursday, Jason. That's why I thought the game was tonight. I don't know where my brain's at. Yeah, so it's Wednesday. The other class just had their very first real bones hands-on class, and I'm pretty sure I saw several of them crying as they left. They were a little terrified of all the bony prominences and, you know, fossas and notches and all that fun stuff. And I told them, I said, hey, the other group will tell you, don't forget them, right? I said, it's going to come back to haunt you if you forget all of them. And well, here we are in, it's just like evil laugh, John's like, I love it. But yeah, they just, you know, I remember you guys when you first had that and you walked out that first class with your face just this glossy, I can't believe in what did I sign up for on Walmart, sounds pretty good right now look. Yeah, they kind of had that same look. But they got through it. It was fun. They definitely were burnt out by the end of it. And, you know, we've got some new tools which have helped. Yeah, I wouldn't doubt that. Yeah, I'm just saying. I don't know that we had visible body while you guys ran. I'm seeing if I can get it actually for this class as well so we can get a copy of it. But it actually gives them, I know some of you have that already. But those of you that don't, they've given us course access to it. So I want to see if I can get it for this class as well. Yeah, I love visible body. I bought it back before like it was cool. I've had it for quite some time. But I think I'm going to start integrating a little bit of it more in my classes as I go along. But anyway, so today we're going to talk about the knee. So we're going to do the same thing kind of we did because this is a knee. So we're going to work our way through some basic pathologies or landmarks of the knee, some basic pathologies of the knee, and then we're going to work our way talking through the goniometry and the man-must test. The good news is the knee is really simple. Asterisk. It's really simple compared to the hip. I'll give it that. So when we're talking about the joint structure, it's typically considered a uniaxial joint, right? Or a 1 degree of freedom joint. But some will argue because of the screw home mechanism, it's biaxial. And we'll talk about that in a bit. So it has flexion and extension and then what we consider accessory rotation. That's why we don't call it a true motion. So that screw home mechanism is when you get into that full extension that locks the tibia in place, right? And use that tibial eminence to lock everything in place. In open chain knee extension, it is a concave surface moving on a convex. So that is the concave surface of the tibial plateau moving on the convex femur, right? And when you get into full extension, the tibia will rotate slightly laterally to lock in on the femur. When you're in a closed chain knee extension, like standing up, at that point it's the convex tibial or convex femoral condyles moving on the concave tibial plateau, and the femur will lock medially. So it just depends upon if the tibia is moving or if the femur is moving, which way the rotation occurs in order to lock in place. But once it locks in place, like I said, you've got that kind of that tibial eminence at the top of the tibia crest. And when that comes in, it's going to find that nice groove between the condyles and it just locks it. And that's what gives you kind of the strength of your knee. It also opens the knee up to many injuries. So here's kind of looking at the tibia moving along with a little bit of a roll, spin, and glide type perspective. But again, if you look at this, especially this kind of cutaway over here, right? Here's that concave tibial plateau, and we've got the eminence kind of right here. And here's the convex condyles. So when that goes into extension, you get this locking mechanism, and that locks it in place. And that allows people to, even if they don't have fully functionally strong knees, you can actually get them to stand and they'll kind of hang on their ligaments. They'll use their ACL and PCL to stand up more than the muscles themselves to hold them in standing. And with the roll and spin, you can see over here, as that femur rolls forward, right, and starts that kind of backwards roll, if it doesn't glide backwards, it's literally just going to roll right off the front of that tibia. So that's why we have that kind of roll and spin going on. So let's talk about bony landmarks again, just a review of anatomy. So with the femur, we talked about this a little bit with the hip, right? We have our head, we have our neck, right? We have our greater troch, which is our big bony side bone on our hips. We have our lesser troch. If we're looking at this from an anterior view, so looking at, oh, this is the anterior view here. What is this called that runs between the two trochanters on the front?
Linea something.
Nope, that's in the back.
Intertrabecular eminence or something?
Okay. So in this case, remember, so in this case, when we're going on the front, it's the line. It's right there, intertrochanteric line. Because remember, if you remember from back when you palpated the bones, on the front, there was almost no kind of lip there. It just was a straight line that kind of cut between them. And I saw somebody say surgical neck. That's exactly right, bro. So that's where they have that surgical neck drawn through it. So when they do stuff like a total hip replacement, they're going to kind of cut right through that intertrochanteric line. That creates the surgical neck. You're exactly right when you're thinking that way. They just typically don't call it a surgical neck as much as they call the surgical neck of the humerus, right? But then if we go to the back side, there's our greater troch, there's our lesser troch. Remember, on the back side, we have this ridge instead. And that ridge is the intertrochanteric crest. Yes and no. So Truman, the intertrochanteric or intertrabecular sulcus is a little bit more superior. So it's this spot kind of here. The line is just kind of formed between them. So I guess you would say just superior to the line would be the sulcus. Does that make sense?
So if you're in like a clinic, what do they usually call it?
Well, in the clinic, they're not going to call it anything. Just being 100% honest. I just want you guys to know this because it's important when you get board questions on it to know that the crest is on the back, the line is on the front. That's the main thing I want to make sure you guys understand. Like, as far as the clinic goes, doesn't really too much apply unless you get into a clinic that is really specializing in hip replacements. And then you just have to understand that the line is where they're actually going to draw the cut line for the surgical neck. So it's not really, I mean, again, this is not a huge problem that you have to understand. I just want to make sure that you know that the crest is on the back, the line is on the front, if that makes sense. The body is the whole kind of meat and potatoes of it, right? It's the shaft, it's also known as, right? On the body, on the back side of it, you have that line that I think it was Riley was mentioning, right? The linea aspera, which is also known as the rough line. I'm getting mad at the boards. They're getting better about it. I'll give them that, Riley. I will say that they've been a lot more applicable than they were in the past. So I just want you guys, that's a weird anatomy question they could ask. I've seen it before. That's the only reason I'm hitting it. On my boards, I had a question about that. And it was just basically like asking me on the front of the femur, what is the space between the two trochanters known as on the anterior aspect, and it's the trochanteric line. You also have a couple other lines that Dr. Johnson really didn't talk too much about, but you have this thing called the pectineal line here. Gee, I wonder what attaches there. It's almost like it's named after it, right? It's pectineus. Right? At the end here, which is important for the knees, because this is the important part we need for the knees, right? We have our condyles and our epicondyles. So the condyles are kind of the part that we articulate on. The epicondyles are the bumps on them. So we have the medial and lateral epicondyle. You do have the adductor tubercle down there, right? And the adductor tubercle is going to be right kind of north of that medial epicondyle in this region here, and it's not drawn very well on this bone. And that's the point where a lot of those adductors are going to attach on to it, right? And allow for adduction of the leg. And then you have the patellar surface, right? Which is that spot where the kind of the patella sits and articulates with the femur. Lots of parts of the femur, right? On the tibia, there's going to be some fun. On the tibia, there's not too many specific points you have to be worried about. You have your intercondylar eminence, which is also called the intercondylar crown. That is between the two condyles of the femur. You have the lateral medial condyle of the tibia, which then would interact with the lateral and medial condyle of the femur. The top part of the tibia is called the tibial plateau. That's what the part that's going to interact with the femur. The big thing for the knee is this big bump on the front, right? That is our tibial tuberosity. Why is that really important for our knee?
Site of insertion.
Yeah, that's our big patellar tendon insertion, right? We have our plateaus, which are the top part. We have the tibial tuberosity, which we talked about. We have the crest, which is that sharp point going down the front of it. And then we have our medial malleolus. The fibula is not truly part of the knee, but it's there, it's near the knee, right? The fibula is a weird bone because in reality, does the fibula do much for us? Because it's a non-weight bearing bone, right? Its main job is lateral stability of the ankle and providing more muscle attachment sites, right? So the fibula, the fine fibula, really doesn't do much for us overall. We can actually survive having that amputated if for whatever reason you need it. I actually had a patient that got lucky. He got a bone cancer, and the cancer only affected his fibula. And they were able to actually go in, remove the whole fibula. They didn't even mess around and say, well, we'll take part of it. Nope, they're like, it's in the fibula. Let's just yank it out. So they did surgery. They cut his fibula out. He lost some lateral stability of the ankle, so they had to do a little bit of an arthrodesis in the ankle where they fused it. But for the most part, I mean, other than the long scar going down his leg, you wouldn't notice he had something wrong with his leg. They don't make like prosthetic fibulas or tibias or anything, fibulas or anything like that. So we have our patella, right? Our calcaneus does have something to do with the knee only because on the back side we have our gastroc, which goes across both joints. So that calcaneus does have to do with the knee, but it's not part of the knee. And the main part of our knee joint when we talk about it is the patellofemoral along with the tibiofemoral joint, right? So that allows for an increase in knee function. That patella there creates a pulley system, which increases the line of pull of the quads. If it goes away, if they pull it out, you actually lose a lot of force on your quads. So it's there to increase function of the knee more than anything. So the Q angle we're going to talk about, and that increases the moment arm. You're exactly correct, John. We'll see if anyone gets the picture in the upper right corner or upper left corner. Almost no one got it last semester, and I was very sad. The Q angle is known as the quadriceps angle, right? So when we're talking about the quadriceps angle, we're looking at an angle that looks at the midpoint of the patella to the ASIS here, right? And then kind of the line of pull of the quads. So if we draw a straight line from the midpoint of the patella up to the pelvis and then off of the ASIS, that's referred to as the Q angle. It's also the rectus femoris angle. I've heard it as a patellar angle. So Q angle is usually what we talk about here. The angle is typically larger in females. Well, I wonder why that is. What's different about the female's pelvis? Wider. Yeah, good, right? So when females have that, and this angle actually gets out here, so the normal angle is between 13 and 19 degrees. Males are usually 14 or under, and females are usually 17 or over. So as that angle widens, right, it affects the pull because the tibia stays straight down here. So you get this odd pull going on the patella, and that can lead to patellofemoral pain syndrome, where the patella, instead of tracking nice and neat between the condyles here, ends up tracking either more laterally or more medially. Sometimes it varies based upon the angle, especially guys. I've seen guys get patellofemoral pain syndrome where it tracks more medially, but ladies, it usually tracks more laterally. So now you've got, so if I've got my bump of my condyles here, so here's my medial condyle, here's my lateral condyle, right? And actually, I like this because this works really well. And normally my patella is kind of gliding between them. And then suddenly that Q angle pulls me where I'm slightly off angle. Now that patella is just rubbing against that condyle. There's some simple things we can do in physical therapy for that. And one of the big things I do, at least, to help patients with patellofemoral pain syndrome is I do taping. So I'll do what's called a medial taping of the knee, where I'll attach a piece of tape here and pull that tape hard that way around the knee. And the idea is it kind of wraps around the patella and pulls it a little bit more medially so that it tracks more smoothly in that patellar groove. I typically do kinese tape, John. We can also do McConnell taping, which I don't like so much. So McConnell taping, I'm going to do a demonstration of both. McConnell taping, I don't know if has any of you ever seen a McConnell tape? And that, we're not talking about like Mitch McConnell being on tape. We're actually talking about a specific, I think it's McConnell tapes. Am I drawing? Yeah, it's McConnell taping. So it's where they use a really, really super sticky brown tape, and then they use kind of a white tape over it to pull the kneecap. There are some people that really love that. That's like old school biomechanic tape type thing. Okay, so yeah, so Oscar says he's seen it, right? I don't like that kind of tape because when you pull that tape off, if there was even a shred of any hair or anything on your knee at that point, it is gone. So it's like getting a Brazilian for your knee because it will take everything with it. Pre-wax, exactly. That may be fine for you, Riley, but it kind of hurts when you have, fuzzies all over your knee. I'm just saying. And usually when I do taping, I might even shave it even with the kinesi tape. And I'm partial. I'm a weird kind of, what do I call it? Like purist. I will only use kinesio tape. I will not use like KT tape. I will not use rock tape. I actually despise rock tape. For whatever reason, every time I use rock tape, it just falls off me. Oh, John's going to say.
I have a question. Are we going to be taught how to tape?
I'm going to teach you the basics of patellar taping. Yes. I mean, when I say basics, I'm talking pretty basic. Dr. Vreskin will do a class, hopefully in semester 5, because she's actually KT tape certified. So I usually bring her in semester 5 for a fun little class where she talks about different types of KT taping, like the shoulder and the knees and the hips. So that's usually a fun little class where it's not a real serious, like kind of learning class where we actually get to have a little bit of fun together. And we all need that by semester 5. Promise me. Promise you. Promise you. We can get KT tape certified. Absolutely, Stephanie. That is not a PT specific skill. I think the KT tape certification requires a 2-weekend course, if I remember correctly. It's been a while since I've seen it, and I am by far not a KT tape specialist, but I'm really good at taping the knee, the shoulder, and also taping for edema. Like that's my main specialty when I've done KT taping is relieving the skin for edema. Yep. So no one gets the picture. I'm very sad. Very, very sad. Where's your generation gone? Very sad.
Apparently nowhere.
Exactly. That's Q from Star Trek, by the way. Get it? Q angle. Q, no, fine.
We already discussed this. We don't know what Star Trek is.
Oh,
No, I'm just kidding.
yeah, QAnon. I could do that too. I didn't think about that, Truman. I should have done that. Gosh.
I got a question though.
Yep.
So when you talk about with the tape, kind of helping pulling that patella, is that simulating what like the VMO does, or?
Yeah. So, well, that's the thing we have to be careful of, right? So the VMO is over here. It's pulling, right? But the problem that we have is the VMO is only about that long, and that quad or that rectus is really long. So that rectus has advantage over it, right?
Okay.
So yeah, so the one problem we could have is when I do that taping, it's going to assist that VMO for pulling it over, but could it also not only weaken the VMO? Yeah.
Sure. Yeah.
Right. So on top of taping, what I want to do is strengthen that VMO to help the pull. So yeah, definitely. And also, you guys, I don't know if you guys know this, but man, you guys will kill Dr. Reskin if you have no idea what Star Trek is. That is, Dr. Reskin is the world's hugest Star Trekkie. All right, so looking at the knee joint, this is where things get complicated. Oh, she'll just laugh. It's okay. Within the knee joint, we have a ton of ligaments, right? We have ACL, PCL, LCL, MCL, and then we have our menisci. So on either side, we have collateral ligaments. And when they're called collateral, it means that there are two of them that are supporting either side. In the elbow, guess what we're going to find? We have collateral ligaments in the elbow too, right? So collateral ligaments, they kind of keep everything inside. I'm going to start with the lateral ones and work to the medial ones, just because I think the lateral ones make the most sense. Or lateral meaning the outside ones. Because we have a lateral collateral ligament and we have a medial collateral ligament. What is their job? Well, the LCL's job is to prevent. So if I'm looking at my knee, right, and I'm going to label this side over here, my medial side, pinky side is my lateral side, right? So that lateral collateral ligament is going to prevent excessive. If I'm going out to the outside, is that valgus or varus?
Valgus?
No, varus is very wide.
Very
right?
wide.
Okay.
Yeah, right? So when I have that, right, that LCL, here's a picture of somebody with bow leg, right? Very wide knees versus valgus, which is knock knee. So that lateral collateral ligament is going to prevent excess varus forces on the knee, right? Versus the medial collateral ligament is going to prevent excess valgus forces on the knee. It's pretty rare that you get a ton of varus forces on the knee. You know, it's not rare. Your knee usually doesn't go like that, even in sports, right? But it is pretty common to get that valgus force. Why might you get that valgus force on the knee where it forces the knee inward?
Weak muscles.
Okay, weak muscles, right? But what sports might have the knee kind of get buckled inward?
Football.
Football, right? It's for tacklers coming in on the outside of the knee. Soccer is a big one, right? Soccer and even some hockey. Actually, there was just a guy, we were talking about hockey a few seconds ago. I've been trying to find the video. It was one of the Blue Jackets players this year, where one of the players came up and he didn't mean to, but he swung at the puck. And when he did, he brought his stick clean in on the side of his knee. And you saw his knee almost make an L. And that was pretty much, I'm pretty sure, an MCL tear right after that. Now, the good news is hockey players can play without teeth. They can play without MCLs. I'm just saying. No, just kidding.
Is there I see, well, not me, but like there seems to be like a lot of and whenever like an ACL is messed up, it also combines it with like MCL.
Yep, we're going to talk about that with the terrible triad. We sure are.
Okay, sounds good.
So think LCL stops varus, and MCL stops valgus. There's not a nice mnemonic I can give you for that, unfortunately. But yeah, Brooke, you're right along the right thought process. Now, let's think about a patient who already has either genu varus or genu valgus. So, patient with genu varus looks like that, right? Patient with genu valgus looks like this. If you are up here in the varus knee, which of your ligaments, when we're talking about the LCL and the MCL, which of those ligaments is going to be stretch weak?
Is it your MCL?
Okay, so you say that's the, okay, are you corrected? What'd you say?
I think it's lateral collateral ligament.
Yeah, so let's think. So here's where my LCL connection points are. So now that is going to be stretched all the way over that varus knee. My MCL, on the other hand, kind of same attachment points just on either side of the knee. That's actually going to be shortened. So that might get a little bit of tight. Right? It's going to be contracted. Exactly. Yep. Good. And then it's going to be the reverse when we get down to the bottom. Right? It just switches kind of knee positions. Is that a huge deal? Not really, but let's say we fix and we're working on, we figure out that maybe the varus portion of the patient's knee is not a structural problem. It's more of a postural problem, the way they're standing. And we start working at getting them to have more straight knees as they're in a standing position. That LCL, if they've got that varus knee, is going to be weak for pretty much life because it's not like a muscle that it retrains. It's been stretched the whole time. So they might be prone to injuries down the line. And a patient that has, especially if you have somebody that's got knock knee, where that MCL is already stretched out as far as can be, that's going to really open them up to sports injuries down the line. So now let's talk about the ACL and the PCL. The ACL, what it prevents is right in its name. So that's a good part about the ACL and the PCL. What their name says is what they prevent. So the ACL prevents anterior movement of the tibia on the femur. So if I'm, again, down here's my tibia, up here's my femur. The ACL prevents the tibia from sliding this way too much. The PCL, on the other hand, then prevents the tibia from sliding this way, posteriorly. And we'll actually talk about, we have two special tests for that. We have an anterior drawer test and a posterior drawer test. And what their job is to test how lax those ligaments are. And I'll see if I can demonstrate it in a second on my knee, because I don't have an ACL. My ACL on my left side is gone. It got shredded and I never had it repaired. So if I put myself in a little bit of an open packed position of the knee and you pull on my tibia can slide about 2 to 3 inches. It's a drawer test. Yeah. So we're going to talk about the different tests in a little bit as well, but the anterior drawer test, drawer like as in like drawer in your house, right? Not drawer. Tests for an ACL, whereas the posterior test for PCL. The nice part is they're really good. And here's a really magical trick. Here's a real magical one. The lateral drawer test tests for LCL ligament. The medial drawer test tests for medial collateral ligament test. So the good news is those tests are pretty much, those special tests are really simple. We're going to practice them as well in class. We also have the lateral and medial meniscus, right? And that medial meniscus is one you hear a lot of patients getting kind of chewed up because of the screw home mechanism. The job of the meniscus is just shock control, right? It's to help when you run from those bones banging off each other. You also have bursae or bursa, and their job is to kind of lift tendons and ligaments off other things and provide some padding. You'll have the popliteal space, which is the space behind the knee, and we're going to talk about the pes anserine, the goose's neck. So this is kind of another look at what we're looking at. We're looking at all these ligaments, right? So you can see the reason why the ACL and the PCL have cruciate in them. It means crossing, because they cross over each other. So cruciate means cross-like. So they make a little cross over each other. Or as I remember it, X go and give it to you, because that's what I remember things as. I don't remember cross-like. And for the next 5 minutes, several of you are going to be sitting there going, as the song is stuck in your head. This picture here, the second picture right below it, has all these bursas. I mean, look at, we got one, we got suprapatellar, prepatellar, deep infrapatella, super infrapatellar. We got all these, the gastroc bursa. We've got all these little bursa back here behind all the kind of pes anserine muscles. Good news is you do not have to memorize them. I can now make Amanda feel better. Whew. But I will tell you, when we start working a little bit with the patella, the one problem a lot of people have, is when they're looking for that superior border of the patella, they some reason think that the bursa is the superior border. So we often think that our patella is actually bigger than it is. Your patella is only about that big. It's not very big at all, right? But when we feel it, we're like, oh, it feels like it's that big. Well, what you're feeling is the bursa that's above it, that suprapatellar bursa. So you've really got to be careful when we're measuring patellas to make sure that you find that superior border of the patella. And the way you do that is you have to kind of palpate a little bit aggressively and get in on bone. Down here, we have that popliteal space. The one thing I want to talk about the popliteal space is look at all this stuff that is passing through the back of your knee, right? We got a common peroneal nerve, right? We've got the popliteal artery and vein. We got the tibial nerve, semimembra, semitenda, biceps femoris, gastroc heads, right? We've got all that stuff that makes up this wall. We got the popliteus in there, right? Because popliteus would obviously be in the popliteal fossa. Could that become an area of impingement for people, do you think?
Yes, very much so.
Yeah, right? And especially if you get something like where you get a swelling in one of these heads that pushes down on the nerves or the blood vessels, right? That can cause all kinds of problems. So taking care of your knees is kind of important, is what I'm saying. It is exactly. So Anthony says, is that why they strike that spot in MMA? Think about it, Anthony, here. If I strike this spot in MMA, look how easy it is to hit two groups of nerves, right? What's that going to do to the foot? It's going to put it right to what?
Sleep.
Yeah, right to sleep. And now that person's walking around and their foot is not working as much, and you're getting a foot drop. Exactly. So any strikes that person has after that is going to be kind of challenging. You can also really damage the knee by damaging the blood vessels, which that's, not so great. Again, when I talk kind of scary type talk in the military, we're trained to slice right through that popliteal fossa. If you can get down that low, you come in through the popliteal fossa and then right through the inguinal canal, because that'll cut right through this really, really big popliteal vein and artery, and then you'll cut through the femoral artery, and it's almost guaranteed that person's going to bleed out. And again, life situation, not like, I'm not just going to do it because, I want to see how much John bleeds. But they are trained to cut through those. In the martial arts, same thing. When we're trained with swords or knives, that's one of the areas we're trained to strike with that. So the ACL, just a little bit more just coverage a little bit more on the ACL and the PCL on that. The ACL's job is to prevent hyperextension and rotational components of the knee. It's also to prevent that anterior translocation, right? It's one of the most injured knee ligaments. females tear the ACLs more than males by about 25%. You didn't volunteer for that, exactly. So that we have three main tests. And why? And again, why do you think they're going to tear more frequently? Again, it goes back to that Q angle, that femoral angle. Because when you've got that femoral angle up top already kind of off, that means your tibia is going to be kind of more of an angle, and that's going to put more strain on that ACL. The other thing is, unfortunately, ladies, you have something that we don't have as males, and that's called estrogen, right? Estrogen just seems to mess with the rest of your body, unfortunately. So that happens. The other thing is, during pregnancy, right, your body releases a chemical called relaxin, right? Relaxin is a hormone that helps the body kind of relax and allows baby to be, you know, I don't joke about this, but I kind of do joke about this. When you think about it, and guys, if you ever want to be terrified, think about this right now. Baby is the size of a watermelon and is ejected from the female body from a hole the size of a lemon. They need that relaxin to allow baby to come out. And I'm sure some of you ladies that have had children will attest to that's kind of what it feels like, a watermelon coming out the size of a lemon. So when that relaxin is in your body when you're pregnant, it also puts these ligaments up for injury because it makes everything very relaxed and you can actually kind of strain them really easily. So I talked about the anterior drawer test already briefly. Lockman's test goes along with it. It's very similar to the anterior drawer test. Right, rooting for it. And then the pivot shift test, I don't like. Again, we're going to go through, we have actually a class where we go through the special tests, so don't worry about these right now. Pivot shift test is kind of an anterior drawer test where we shift around the tibia, and it's probably one of the most uncomfortable tests you can do in the knee. I don't like doing that to patients because that just hurts even if your knee is normal. And it's not got a very good specificity and sensitivity. The anterior drawer and the Lockman's test both have pretty high specificity. I want to say on the chance of the Lockman test, I want to say the specificity is like 0.93. So what that literally means is if you get a positive test, 93% of the people that had positive tests actually had ACL tears. So that's a pretty good test. We can do conservative management. Not all ACL injuries require surgery. We're going to put a safe environment to protect the knee. We may brace it. And then we're going to strengthen the knee, mainly proximal strengthening that quad. One of the reasons why I haven't had to have my ACL repaired, well, I had it repaired once and it retore, is because I just strengthened my quads, and now my quads kind of serve as my ACL for me. Maybe later on in life it might be problematic, but right now I'm okay. Open kinetic chain exercises can really help in kind of later stage conservative management. We usually start with just closed kinetic and strengthening those lower extremities when we have conservative treatment. When we have surgical treatment, they're going to go in arthroscopically and repair it. They can do a couple of different types of repairs. They can do an autograft here. Auto meaning from yourself, where they'll steal part of the gracilis. They may steal part of the TFL. The main one that they steal from is the hamstrings. And I always question this thought process here, because if I'm already having problems with the knee not being able to fully lock out, and then I do surgery and I steal part of my hamstring, a lot of times that can cause more knee contraction. And so they get stuck out of it. Typically, they'll do a bone patellar tendon transfer where they just make a fresh tendon going from that ACL. An allograft is from a human cadaver. Allo meaning from the same species. So they will literally graft somebody else's ACL into you. And then if it's a serial killer, like the horror movies show, you'll become a serial killer, right? Isn't that the way it works? Anyone ever see any of those movies where like they graft what was that?
No, thank you, Dexter.
Thank you. I don't want cadaver parts in me. The other thing they can do is called a xenograft. Does anyone know what a xenograft is?
That from
Uh,
the pig?
I think it's
Yep.
from like a person that's not related to you.
Well, xenograft is from a pig usually. The other thing a xenograft is they actually, this is really cool. I just watched a surgery on this. They did a 3D printed ACL. Like, to me, that was I don't know, maybe I'm a geek about this kind of stuff, but like thinking about the fact, yeah, it worked. They did a 3D printed ACL, and it's actually been really strong for the patient that had it. To me, that's just amazing. Like thinking about the future where we may actually, and I guess they somehow used some of his DNA to 3D print it. I don't have it. I have to find it. I was watching it about a month ago, so I'll find it again. But think about that though. In the future, we may be able to like think. You have heart failure. We may be able to 3D print you a new heart. Like, to me, that's pretty cool. Now, unfortunately, it'll probably only be the rich people that can afford it. But hey, I mean, at least it'll exist. With the PCL, it restricts that posterior tibial translocation. It occurs a little bit less than ACLs. I tore my PCL too, but when I tore my ligaments, I had a very aggressive defensive linebacker decide that he wanted to see what my knee looked like on the inside. So literally, he put the crown of his helmet on my kneecap. And it just basically blew up my knee. I don't remember a lot of that. All I remember is when I was laying on the ground, the trainer had come off the side of the field, so back in high school, and the trainer, smelling salts under my nose, and the trainer's like, hey. And I'm like, oh, God, something hurts. And he's like, don't look down. And I'm like, why don't I want to look down? And I looked down, and my leg formed an L. And I'm like, oh, that's why. And then I woke up in the hospital. So, yeah. I tore my PCL because he actually literally bent my knee backwards like this. It's really hard to tear that PCL usually. The ACL is kind of the more common one. It's caused by trauma in the knee. Motor vehicle accidents are usually where I see it. Usually when they're having it, they'll have moderate knee joint fusion. With the ACL, I don't see a lot of swelling. It's more pain. If it's a complete ACL tear, are they going to have any pain? Think about it for a second. If it's completely torn, is there likely to be any pain?
Yeah, I think there will be pain.
There'll be a little bit initially, but probably within about 2 days, there's no pain in that knee anymore because you've ripped the nerves off. Just instability. Exactly. Right. And we're going to talk about that actually in the other class in Therex tomorrow. We're going to talk about the grades of strains and sprains of the ACLs and the Ls, the ligaments and the tendons, because that's a full tear. At a full tear, most of the time you have pain for maybe a day after, and then it's like nothing. Whatever. It's just really unstable. Right. And John says his kept popping in and out. It's exactly what, I mean, I've gotten a little better at it, but initially when mine happened, that's what happened. With it, there's posterior drawer test. I don't even know what the Godfrey posterior tibial, it's the SAG test. Why do they do this freaking stuff? So the test is just known as the SAG test. And literally, it's exactly like it sounds. We'll put the person at about a 45-degree angle in hook lying. And if the knee drops backwards, that's a positive SAG. But like I said, we're going to go through all those special tests, including the active drawer test. The only drawer test we won't do is the pelvic drawer test. We won't check to see if people are wearing drawers. Just joking. Come on, that was kind of funny. With PCLs, most time we're going to do conservative management, open brace and crutch it. A lot of PCLs we just leave alone, just because it's pretty unlikely you're going to kind of shift that tibia backwards. They can do grafts. A lot of times for the PCLs, they'll steal the tendon from the Achilles tendon. And again, that can cause other problems. So this is one of the problems we have. I would rather honestly have a xeno or an allograft versus them taking one of my autografts, just because I don't want it that way. The MCL is, so if we go back here and we see that the ACL is a commonly torn one, the MCL is probably the most commonly torn one. Just because you have that force to the knee, right, where you get that severe valgus force. We'll talk about the grading in next class. Don't worry about that right now. Clinical stress evaluation is the valgus stress test or the valgus drawer test or the medial drawer test. With rehabilitation, it depends. If it's an isolated grade 1 through 3, meaning that there's partial tear, usually they'll do no operation on it. And they'll just conservatively treat it and let it heal, mainly bracing it. If it's a complete and utter rip and gone, they may have to reattach it. The neat thing about the MCL as compared to the other kind of the L's, the ACL and the PCL, is if you've only torn the MCL, usually within about 5 to 8 weeks, you can get back to normal sports. So if you're going to tear one, I guess that's the one to tear is what I'm saying. The menisci. No joking. That's kind of funny. The menisci are common injuries among athletes just because of their shock absorption. They do kind of tear frequently. 75% of it is collagen type 1, so really heavily shock absorbing, right? Low transmission type things. It does help with joint lubrication, mainly because it helps keep the joint bathed in kind of that fluid or that effusion. You can have a couple different tear patterns. You can have horizontal, longitudinal, degenerative, where it literally falls apart, or a radial or a spiral tear of it. I will say this about meniscus tears, because one of the treatments we can do for it is actually surgery. But what I've found is when patients have meniscal tears, oftentimes if they go in and clean out the meniscus, they come out worse than they did when they went in. I don't know. Or at least most of the people I've seen that have had a meniscus repair will say they kind of regret actually having the surgery because it's more painful after the surgery.
So is it that they get more infected, or what's the problem?
Well, the problem is now if they go in, they're going to do what's called a meniscectomy, right? Where they trim off part of that meniscus. They typically don't replace it with anything. And then, right, exactly, John says, now there's less cushion there. So now you're getting one area of your knee where it's kind of bone on bone. There are some artificial stuff coming up. They can do these things called Synvisc injections. Synvisc is a kind of a gelatinous protein that they can inject into your knee and acts as kind of an artificial meniscus. It's made from rooster comb, so the part of the red parts of the rooster. But eventually that breaks down too. So you can only have so many of those Synvisc injections before literally it's not useful anymore. A lot of times, if you've torn your meniscus, you're probably starting to go towards a total knee replacement eventually down the line. Because again, once that's kind of cut out, bang, 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 joint on or bone on bone, and it's going to cause you to get osteoarthritis. So Brooke asked, I'm confused about the meniscus. Can it break down or just due to friction and loses fluid? Or how does it work? Well, that's really, actually, you just answered yourself partially. So the meniscus breakdown occurs a couple of different ways. As we get older, right? So if we were to open up your knee and open up my knee right now, Brooke, my meniscus themselves are going to be less vascular than yours are because as time goes on, the blood supply to the meniscus actually breaks down. So they start becoming less and less hydrated. And they kind of get really kind of chalky. I actually saw when we did a total knee replacement, I was in a surgery for a guy who was around 80. Literally, the meniscus looked like a dried up mushroom, is the best way I can put it. Like if you took and you sliced like a shiitake mushroom clean in half and made a little thin slice of it, that's what it looked like. It was really dry and kind of cakey. So that's one of the reasons they're going to tear. They can also tear because you just put a lot of stress on them. Like for myself, I found I really started having meniscus problems back kind of in the mid-pandemic because I don't know if you guys noticed it or not. I hope you didn't notice it, but my weight went all the way up to about 285 pounds. I kind of got it like a chunky monkey. And so then when I went back to exercising, I had all that weight coming down on those knees. And women tend to have more injuries to the meniscus, not as much as the ACL. But it just depends. It seems like it's less. So what I've noticed with an injury, weight can lead to it. Absolutely. The heavier you are, the more it is. They say for about every, at least in one of the articles I read, they said for every 10 pounds you are overweight, it adds about 100 pounds on your meniscus of force. Now, granted, The meniscus are designed to take force. They are designed to be beaten up. But just like anything else, right? If you have a trampoline long enough and you jump on it every day, eventually that trampoline is going to start to sag, right? Same thing can happen to the meniscus. Beating them up year after year after year. So a lot of what I've seen in the clinical world, and again, this is anecdotal coming from me, not research-wise, I've seen there's two different patients I see that come in for meniscus injuries. Really, really super active people and really, really sedentary people. So those patients that don't do anything, that don't get up and don't move, and their meniscus kind of dry out. And then people like, you know, that do tons of CrossFit or Tough Mudders and are really beating up their knees. I see them as well. And again, I like to pick on CrossFit. If anyone here is in CrossFit, I'm not picking on you in particular. I appreciate CrossFit. Here's my theory on CrossFit. It gets you out and gets you exercising, great. But it's also job security for me. I'm just going to say it. It is, especially if you get a bad CrossFit gym. And there are a couple of those. So there's a couple different tests we can do. There's the Epley, I'm sorry, the Epley is for another thing. The Apley, the McMurray is the more common one. There's a Steinman and a Thessaly. Really, when we talk about these special tests, they're all bad charging $200. Is that really how much it costs? Funny story I can tell you in about like 2 seconds. I had an old coworker that drugged me to one of his CrossFit gyms. And he's like, just want to warn you before you go, the guy that leads the gym, he's kind of a jerk, but it's kind of funny. He makes up mean names for all of us. It's like, you know, if you've ever seen Super Troopers, I'm Chicken Effer. That's his nickname for me. So he'll come up with a nickname for you as soon as you come in. And like, he came up with the most racially charged nickname for me that I've ever seen. And I was like, this is not a gym I want to go to. Like, I don't understand. That's kind of like Dick's Last Resort, the restaurant, if any of you have gone to it. I don't want to be insulted while I'm sitting there eating. But I think that'd be a fun class trip for you guys. You should go to Dick's Last Resort as a class. Yeah, have you ever been there? Any of you been there? Joe's been there. I can see he's laughing. Wouldn't that be a fun class trip? Like, just imagine. Like, just all of you in that one long table, and just imagine what they're going to do to you. I'm just saying. Maybe make it a suggestion. I am not paying for it, but. So the Pez Anserine. The hats, oh no, exactly. The Pez Anserine, yeah, I won't even tell you some of the hats. I want to know what some of the hats would say, exactly. The Pez Anserine is made up of SGS. This is the way I remember this one. And the reason why, so let me show you my little trick here. And if this doesn't work for you, I understand it, but this worked for me. So SGS. That's how I remembered what muscles made up the Pez Anserine. So I have my sartorius, my gracilis, my semitendinosus. It comes down here and attaches onto my tibia on the medial aspect. It's a place where you can get a lot, there's a couple bursa in there, but you can get a lot of irritation in there. So your boards do like to ask you questions about the Pez Anserine, mainly what muscles make them up. That's why I created this SGS mnemonic for myself. Because again, Pez has an S, Anserine has an S. You could just say SSG if you want to remember it that way. I just remembered SGS because of the order of it. But whatever helps you remember kind of the muscles. And again, it's common for runners to get pain here, and not only here, but also out here on the lateral aspect because of that IT band. I guess I'm just saying running is bad for you, right? I'm just saying, like, just don't do it, right, Sydney? We're just not going to run anymore. How's that sound?
Sounds like a plan to me.
See, I knew you'd agree with me on that. I just knew it. We've talked about this before, right? So on the anterior aspect of the leg, so going down that front side and going across the knee, right? We have the rectus femoris, our 2-joint muscle, and then we have our vastus group, right? But we also have that little last part of the vastus group down here, that vastus medialis oblique that we have to think of as well. Posterior muscles, we got a whole mess of them, right? We got semimembra, semitenda, right? And then we've got biceps femoris. We've got popliteus. So real curiously, what is popliteus's job? Because it's a tiny muscle. What's its job?
Is it medial rotation of the extended knee?
Yeah, it helps lock and unlock the knee. Exactly, Joe. And that's right, the medial rotation. Exactly. The main job is just that locking and unlocking part, right? It works to lock it one way, and then there's a muscle reverse action to unlock it. So it's just important to understand that that's there, but once that gets tight, that's going to compress everything down under there. Your gastrocnemius, otherwise known as your big old calves, right? TFL, tensor fascia latae, or I forget how that lady said it yesterday. It was like tensor fasciae latae. I don't remember what she said. It was kind of funny to me when we were talking about those videos, watching those videos. The gracilis, again, which you follow north, will go to Graceland. And then the sartorius. What's unique about the sartorius? Does anyone know what the special thing about the sartorius is? The neat little fact. Okay, it is S-shaped, yeah. It's the longest muscle in the human body. Right, look at how long that sartorius is, right? It goes all the way from that ASIS down to that medial tibia. So it's one of our longest muscles in the human body. Funny fact about that, cohort 10, I think it was cohort 10. Is it cohort 10 or cohort 9? One of your models is missing a sartorius because they broke it. I don't know why, it's just a fun fact too. They broke the sartorius. The only muscle they broke on it. It was them, yeah. I won't say who it was. Just because I don't want Ian to get in trouble. I mean, I won't say who it was. So then we've got we're looking at some pathologies now. So we're going from just looking at the structures to looking at what can happen. If you get a paralyzed quadriceps, what do you think, what could cause your quadriceps to be paralyzed where they're not working anymore? What type of an injury?
A tear?
What'd you say?
A tear?
Kick tear, right? Specifically of a nerve, right? Tear off. And SCI is the big one, Anthony says, right. Specifically like a spinal cord, not really a total where you're like breaking the spinal cord, but maybe where you've had a collapse of one side of the spinal cord. Interestingly enough, even if your quadriceps are fully paralyzed, you can extend the knee, which is like, to me, is really cool. The gluteus maximus can help pull back on the femur and extend it. The gastroc can help pull the femur into extension. And then the soleus will pull up on the foot a little bit in reversive muscle action. It'll actually lock the knee out. I actually had a patient like this where they ended up with, they had a real bad, it was a football injury where the stinger actually, where they nailed with the helmet into the quad, separated out the quad, the actual nerve right off of the quad, and it wasn't regrowing. So the quads were completely paralyzed on the person. And we had to use reversal of muscle action to teach him how to lock his legs so that he could walk. It's actually kind of cool that even if you have a paralyzed quads, you actually can still achieve knee extension. Pathologies, genuvalgum, genuvarum. I think I've covered those ad nauseum. Are we okay on varum and valgus of the knee at least? Right, varus, very wide, or where you got bow leg, valgus, where you got very, those form the L, and that's knock knee. Do you guys remember what genu recurvatum was again?
It's like hyperextension.
Yes, hyperextension of the knee. Good. Patellar tendonitis, exactly like it sounds. It's where the patella tendon really gets inflamed and gets angry. It can go along with Osgood-Schlatter's disease. It's just one of my favorite diseases of the human body because it just looks so cool. Osgood-Schlatter's, right? Osgood-Schlatter's is an enlargement of that tibial tuberosity, particularly of young boys. What is, Diana, what was no? Before I go further.
Oh, no, you're fine. You're fine.
Okay, good. No, sorry. Osgood-Schlatter's is where that tibial tube just really grows faster than the rest of the body. And that puts the a strain on that tibial tendon. So I'm sure that probably more than one of you guys that are in here had it, and some of you may have had it and didn't know it. One of the students from cohort 8 once, let's see if I can find the x-rays of it, but he actually brought x-rays of, it is common, well, it's common to cause patellar tendonitis, Anthony. Patellar tendonitis just occurs just from overuse of extending and flexing of the knee, but this can really lead to patellar tendonitis. As far as what causes Osgood-Schlatter's, it's just a weird growth problem in the bones. It happens in, it's one of those where for whatever reason, that tibial tuberosity grows faster than the rest of the bones. Usually evens out as you hit puberty and get into like adulthood. But for especially boys, and it can be painful for girls. I've seen a couple girls with it as well. Man, that section underneath the patella, so that last kind of bit of the tendon, really just hurts. And so a lot of them will come in saying rubbing right below, and like, man, right below my kneecap, it just hurts so bad. And it's usually kids. Baker's cyst, this is not from baking. The baker is the guy's name that kind of founded it. Baker's cyst is where your the bursa on the back of your knee kind of swells too much, right? This is also known, you also encountered this if you ever played the game Operation. You remember what it was in Operation? It was the bucket. You remember that from Operation? Any of you ever play Operation, the game, right? You had to pull the bucket out of the knee. It was water on the knee, right? But this Baker's cyst is where that bursa, that game scared me as a kid. They actually have a new version now with like Jack Skellington from, what do you call it? Nightmare Before Christmas, but anyway. The alien version sounds like fun. I like that. I'm going to have to look that one up. But when this swells, there's only two things we can do. We can do conservative treatment where we're going to ice the back of the knee and hopefully get the swelling to go down in it. It's just one of those where for whatever reason at that point, that Baker's cyst just swells up with fluid. That bursa really fills up. The other thing they can do is they can aspirate that cyst. And by aspirating, they'll take a really kind of tiny thin needle and they'll put it in. You can absolutely, Brooke. Mm-hmm. It looks like a bump covering that popliteal fossa. And they'll say, I can't fully bend my knee because that bump is back there. It kind of looks like a giant blister when it happens back there, but it's not like the transparent type blister. It just kind of shaped like a blister, if that makes sense. So it can go down naturally with rest in, kind of ice and compression and stuff like that. But most of the time, a surgeon will come in, put a needle in it, and then just suck the fluid right out of it, right? And that'll decrease it. The downside to it, Baker's cysts are kind of one of those things like herpes. Once you get it, it tends to come back and come back and come back. So Baker's cysts oftentimes will reoccur, and it's just because, for whatever reason, that bursa back there just doesn't like you anymore and wants to swell and get angry. Some other pathology get PFPS, or patellofemoral pain syndrome. It does have to do with friction. It can deal with friction, and it can also just be idiopathic, meaning it just happens. So PFPS, or patellofemoral pain syndrome, typically due to that maltracking of the patella. You can get prepatellar bursitis, which is a little bit less painful than a Baker's cyst. That is where that bursa above the patella kind of gets swollen, irritated. We can have the unhappy triad, or the terrible triad, which is the ACL, the MCL, and the medial meniscus. So ACL, MCL, and the medial meniscus. That is a common sports injury. I have a great video of that coming up here. We'll see if we watch it here towards the end. I'm not going to watch it right now. We'll come back to it. And then I have a video of total knee arthroplasty. I'm not going to watch that with you guys, but if you're interested, that's just like the total hip arthroplasty. I put that there in case you're interested in watching it and you really want to be a sadist like I am. The total knee arthroplasty is probably more painful to me to watch than the total hip arthroplasty, to be 100% honest. can have this thing called, I love this, for whatever reason, this syndrome makes me laugh. The miserable malalignment syndrome. It sounds like a curse from Harry Potter, doesn't it? Like miserable malalignment syndrome. PFPS is typically caused by maltracking of the patella. So again, for ladies, it typically goes back to the Q angle. For men, oftentimes, it's a weak VMO. And I guess ladies, it technically could be both the Q angle and VMO weakness, John. Miserable malalignment syndrome is exactly like it sounds. For whatever reason, the tibia and the femur don't line up right. Could be a bony problem, or maybe one of the tibial plateaus has a crest on it where it shouldn't. It can be that the tibial crests are too deep and the femoral condyles are too shallow. It just means that that bone itself, when those meet up, they're not meeting up like they should be, and there's a lot of play in the way those bones meet up. And what it's called miserable malalignment syndrome, because if your bones don't meet up nice, that knee just hurts, right? It can happen long-term because of osteoarthritis or even osteopenia and stuff like that. But mainly it's just a weird shapement of the bones. Like I said, this terrible triad video, I just want to watch you guys watch in a second, but not right now. We'll come back to it in a second once we get through the rest of this. How do we rehab any knee injury? Well, the main way with the knee is we have to have a working knowledge of the basic science of the knee, right? To adopt a team approach, creating a safe environment, don't hurt the patient. With the patient, doesn't matter what the knee surgery is, whether it's ACL, PCL, MCL, LCL, meniscus, total knee replacement, half knee replacement, whatever it is, you have to be aggressive with that patient, but you also have to be safe. The main thing I have seen that occurs with patients that have had knee surgery ends up being paralysis of some part of the quads, right? So where they lose extension. That is why I put down here, the number one thing you must work on with your knee patients is extension, 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 extension. There's a lot of studies that show at the 1 year and then at the 2 year mark, after a total knee replacement, a meniscal repair, after a ACL repair, if you have not gotten full extension back at these kind of 2 time landmarks, you will never get full extension. So you'll be constantly stuck in a state of a partial flexion. So you want to make sure that you're hitting extension hard. You can get flexion back years later because the knee flexes a lot easier than it extends. Yep, during the acute phase, we want to extend that knee as much as possible, right? A lot of patients will want to put a pillow under their knee no matter what the surgery is, because the pillow makes the knee feel better. Oh, feels good. But the problem is, if I put a pillow under my knee, I create it in a flex position, and they can actually get stuck that way. So we need them to be extended. I'm a mean person. When they ask for a pillow under their leg, I put it under their heel, because that way it creates a force arm down here where the knee is forced to drop into extension. You didn't tell me where to put it. Just saying, you said put a pillow under my leg. There's a lot of different exercises. Quad sets are key, 100%, right? And, I once had a guy that was really aggressive. He had a total knee replacement. He was like in his 50s. And he said, well, what's the one thing I have to work on? I said, extension. He's like, well, how many quad sets is too many? I said, there's no such thing. So literally, he took me at my word. He was doing like 400 quad sets a day. He was determined because he wanted to get back to doing, he was a triathlon runner. He wanted to get back to running again. And he's like, man, I told him, like, if you don't get knee extension, you're probably not going to run triathlons again. And so he ate at it and sent me a picture about a year later showing how he did his first triathlon after total knee replacement. I love him. I wouldn't want to do that. Follow a functional progression. Most of your surgeons in this area have a very specific protocol for their knees. One surgeon in this area specifically, I'll tell you, Dr. Johnson, not our Dr. Johnson. There's another Dr. Johnson in town who is an orthopedic surgeon and has privileges at most of the hospitals here in town. Really good guy. I love him. He's a fantastic guy. He has a very, very, very specific protocol for all of his surgeries, specifically his ACLs and his total knees. And if you do not follow his protocol, he will stop sending you patients because he has a specific way he wants his knee treated. And honestly, at that point, we just say, yes, sir, Dr. Johnson, we will do your total knees and whatever the way you want them. He's a great guy, kind of scary, but he's not like our Dr. Johnson. Our Dr. Johnson's kind of a cream puff. But he definitely has his own protocol for the knees. So I'm just warning you, if you get one of those, make sure you follow his protocol. And then follow an assessment-based guideline. Yes.
Sorry, I just had a question. Since you were talking about like extension, right?
Yep.
So if someone has issue with, in this case now, flexion, is that just because of strength and like just tightness?
Typically, yeah. Yeah, especially if they have a problem with flexion, it's usually tightness or maybe a little bit of weakness combined with tightness. So yeah. And again, the nice part about flexion is we can torque on that knee pretty heavily into flexion. I mean, think about how much easier it is to pull that knee into flexion than it is to kind of push it into extension. We're designed to go into flexion, right? It's not as easy to get extension out of it. I mean, I guess I could sit here and push down on my knee, but no patient's going to do that. Where they'll bend their knee all the time. Like they have no problem doing heel slides and anything you want them to do that way. They just don't like doing the extension activities because it hurts. And again, think about it. So here's my patella, here's my front part of my femur, here's my tibia. Most of your surgeries are going through this anterior compartment, right? And so again, when you extend it, that's getting stretched and kind of pulled, and it feels uncomfortable.
Thank you.
Yeah, no problem. All right, open versus closed packed. And this is to mobilize either the knee or the kneecap. Because remember, closed packed, stabilize, open packed, mobilize. So open packed of the knee is about 25 degrees of flexion. And I've read anywhere from 25 to 45 degrees of flexion. The main idea is kind of a hook lying position, right? If we have the patient lying on their back, right, here's their laying on their back, there's their hip, there's their knee, there's their foot. A hook lying position about puts them in that 25 to 45 degree angle, right? That's a good position to mobilize both the kneecap and the knee itself. And that's also going to be the position we do our special tests in usually. Closed is full extension. That makes sense. You're not going to mobilize the knee when you're fully locked out. I hope that makes sense. A capsular pattern. If the patient has a capsular pattern, again, that means we are going to mobilize the knee. They have a greater limitation in flexion than extension. So if they have a limitation in flexion, which John just asked about, it may be weakness, it may be tightness, but it may also just be a capsular problem. And then we're going to mobilize the knee. Excuse me. We can do anterior, posterior, medial, and lateral mobilizations on the knee to kind of loosen up that joint capsule to allow the knee to flex a little bit better. It's very rare if the patient has a limit in extension that it's actually a capsular pattern. So full range of motion, 0 degrees of extension. That makes sense. The knee should be straight, right? Here's my kneecap. The knee should be straight. That's a weird looking ankle. Flexion is about 135, right? So if this is 90, forming the right angle, 135 goes about 45 degrees past that. Now, is everyone going to be able to achieve 135 degrees of knee flexion?
No, because of soft tissue approximately.
Exactly. Specifically like myself, I know I'm not. I got big chunkin' hamstrings, right? Diana may be able to because she got kind of tiny legs. Well, I'm not saying tiny, no muscle, just tinier as compared to me. And Truman, because he skips leg day, he might be able to as well. I'm just joking, Truman, just joking. Truman doesn't have chicken legs. And we've all seen that guy at the gym that has chicken legs. We know that person can reach 135 degrees in knee flexion. But yeah, so a lot of people get soft tissue approximation before then. Does that mean they're not functional? No, they have functional range of motion, right? But they just kind of lack that because that soft tissue comes up, especially if you got somebody that's got like me, where you've got huge calves and huge hamstrings. I don't think I hit 110 degrees, honestly. And it's not limited by my quads. My quads are pretty loose. My hamstrings are tight. There is some of this medial and lateral rotation. I'm going to tell you here, I'm going to make Riley really happy here. Your boards typically do not ask you about this, the actual degrees. So that's one of the areas, for whatever reason, they choose not to ask about that. What this is saying is at 90 degrees of knee flexion, you have about 45 degrees of rotation to the lateral side and 15 degrees of rotation to the medial side that you could actually do at the knee. I think the reason why we don't ask questions on this is because that just seems really obscure, right? Well, if I hold the patient at 90 degrees knee flexion, I can actually rotate their knee 45 degrees. Why? It just seems weird. I don't know. But you do have to know these normative values, right? So the 0 to 135. Functional range of motion. Again, this is more what we are concerned with from a physical therapy standpoint than anything. For gait, they really need, and if you look for gait and stairs, they really need to have 0 degrees of extension to be functional, right? So we got to get extension, extension, extension. Walking on a surface, we need about 0 to 60 degrees, and then extension definitely should be 0 to be functionally with gait. So 60 degrees of knee flexion gives us normal function for gait. This is the one, if you memorize nothing else from this lecture, please know that number, 0 to 90. Because this is one, again, that the boards love to ask questions on. What is the normative functional range of motion at the knee required for ascending and descending stairs? Well, I need to have 90 degrees of knee flexion. In the hospital, when a patient comes in for a total knee replacement, that is what we are shooting for at minimum, to get them to 90 degrees of knee flexion, because that way if they encounter a stair, they can go up and down the stairs. For goniometry and manual muscle testing. For goniometry, your landmarks for testing. Again, I'm going to get my big goniometer back here. Right? So for bending the knee, my fixed arm, here's my fixed arm, is going to line up with my greater troch. My vertex is going to line up with the lateral epicondyle of the femur. And then my distal is going to create an imaginary line that lines up with my lateral malleolus. So that when I bend my knee, I get a range of motion out of it, right? And again, most of us are going to get between about 100 to 120 degrees for the most part. That's for both extension and flexion. What do you think the position is for goniometry of the knee? What position are we going to put them in? I forgot to put that on the sheet.
Prone.
Short sitting?
Okay, so I heard a lot of them. And here's my answer to that. Yes. You can actually do knee goniometry in just about every position. You can do it in prone. You can do it in seated. The only one you really can't do it in is long seated because the knee's already extended. I guess you can measure knee extension there. Sure. By the book says supine. Right? Now, again, I'm going to tell you guys this. You're not going to get a question on your boards asking you what specific question or what specific position for goniometry. That's not what they're going to ask you about. They're going to ask you about the values and where your landmarks are. So it's very, some of you, one of you will come back with a question like this. I'm going to say, 99 times out of 100, you're not going to get a positioning question. you're going to get a question about the landmarks or the range of motion or both. Meaning you may have a combined question where it's asking you what are the landmarks for goniometry of the knee along with the norm values. So by the book, supine is technically the position, but yeah, honestly, when I do goniometry of the knee, I do it in short sitting. Just because it's easier for me. I don't have to have the patient lie down. John?
Yeah, would they, sorry. Would they, when they ask about like for the range of motion, would they specify if it's like full range of motion or functional range of motion?
Just say, what are the normal values based on AAOMT, which is the Academy of Orthopedic Manual Therapists, which is what we go by. That's just at 135. So you just go with 0 to 135.
Okay.
Right.
And then second question on that one is that like with functional range of motion, I've seen therapists measure with like with passive, not passive, but like with like active assist really.
Mm-hmm.
So for functional range of motion, would that is that how we would measure them with like a belt or something?
If we're measuring functional, it has to be active motion because functional indicates the patient's doing something, right? So if we're going to measure functional range of motion, we have to measure it with them doing the full motion themselves. And we can measure active assist, we can measure passive. That's great. We just have to document, like if we say you're measuring me as a patient and you measure my passive range of motion. You just have to indicate that the measurement you took was passive, right? What about end feels? So let's talk end feels. So we have extension and we have flexion. What do you think the end feel extension is?
Bony.
Bony.
Maybe. It's more firm. Yeah. Because here's the deal. I can come up to, Bianca was the last one to respond, so she gets the torture here. I can come up to Bianca and put a hand above on her femur and a hand below on her tibia and actually extend her further than 0. Because the muscle will give a little bit, but it'll eventually be a really firm end feel. Sometimes, especially if you have a really skinny person, you'll get a bony end feel when that tibial condyle kind of locks in. But for the most part, it should be firm because there's still space between the tibia and the femur because you've got that meniscus in there. So most of the time it's firm. Flexion, it could be 2 different ones. What are the 2 that it could be? If there's no meniscus, for sure, absolutely. If the meniscus are pretty much chewed up, it's going to be bony. Yeah, that would be a pathological one, right? What about flexion? Soft would be one of them, right? Could we get a firm one there? If we have a really skinny person, right? We had one girl, I want to say it was, she was cohort 5 or 6. I can't remember which it was. Tiny girl. She was probably like literally 4'11", 4'10". And she like, I swear to God, she was like, I think when we measured her, she was like 75 pounds soaking wet. And she definitely had a firm end feel, and she got 135 degrees. We actually got 142, I think, out of her. And it was definitely a firm end feel because she didn't end up with soft tissue because she like had no meat on her whatsoever. It was kind of funny. Like that was the first time I've ever actually encountered a true firm end feel there. But also if we're tight, right? So if we tested John's, we may end up with soft tissue, but we also might end up with a firm end feel if he's tight. Right? If his quads are nice and tight. So we could end up with a firm here. And again, like I said, with extension, we could get a bony if the person's super skinny. Or like Anthony said, if there's no meniscus. When would we get a boggy end feel of the knee?
Like with edema?
Yeah, good. See, you guys remember that. And there's actually this really cool test we'll do for a boggy end feel where if, and I have to find a great video and I've got to find it. We'll talk about that's on a special test day. But there's this really cool test where they actually have a video of somebody that has really, really bad lymphedema, and they do what's called the wave test, where they move the finger up and across the patella. And when they do that, the edema literally makes a wave and rolls back down the leg. It's really weird looking. That's when you know you've got some serious swelling, when your leg makes a wave. So we're going to measure both knee flexion and extension, 0 to 135. We do have muscle length tests, so we're going to go through each of these special tests in special test day. Baker's would be boggy, or it could end up being soft depending upon how it is. I've even had firm with it. With Baker cyst, Anthony, when that Baker cyst is really hard. Like, it can swell to where it becomes hard. It could be abnormally soft. Yep. Exactly. Abnormally soft knees. They sound so tasty. All right, manual muscle testing of the knee. We are going to test knee flexion and knee extension in the aggregate. There are different tests for different positions of it. We're just going to test general aggregate knee flexion extension. So if we're talking about flexion, I'm going to do my little diagram here real quick. We're probably running at the end of the day here. We are. Extension. Then we got 3, 4, 5 position, and then we have 2, 1, 0 position. What do you think the 3, 4, 5 position for knee flexion is to go against gravity?
Short sitting.
Okay, so short sitting, I'd be kicking up, right? So that would be for extension.
Got it.
Could do standing. Mainly the way we're going to do this one is prone. We're going to do a hamstring curl. But the good news is, what do you think the gravity eliminated position is for both of these?
Sideline?
Yeah, right? Remember, we talked about anything that kind of happens in that sagittal plane, the gravity eliminated position is sideline. We move it into the frontal plane. So with deflection, I'm going to put the patient on their belly. I'm going to have them kick up to their butt, right? Okay, great, Mr. Patient. And we'll go over this a little bit more, don't worry. And then I'm going to push down, and I'm going to push them down, and I guarantee we're going to cramp somebody in here. We'll try it. And then knee extension. Well, actually, we did both of these, didn't we? We did these in anatomy. Now that I think about it, we did these exact positions in anatomy. I just thought about it. I was like, oh, yeah, they're not different than what we taught in anatomy. Oh, what time is it? It's 4:52. I plan on doing that first thing tomorrow. I'm going to actually move the midterm back a little bit, Truman. So I'm planning on doing that first thing tomorrow, because I have a long day tomorrow, right? I knew I had a short day today. All right, let me clear my drawings here. I think that's it then for this lecture, if I remember correctly. It should be black screen. Yep, there we go. So first thing tomorrow, we're going to do it. I thought no, I didn't send an update. That's right. I got sucked into a meeting. I forgot about that. I was in a meeting for like 4 hours this afternoon. It was loads of fun. Let me tell you. Don't be scared of midterms. Hey, guess what? I don't know if you guys noticed this, but hold on. Let me log back in here. Oh, what do you mean I have no username? I exist. Hold on here. Screen share really quick, something. Actually, I want to move that out of there because I have other stuff open. I don't want you guys seeing that stuff because that was related to grades. So gotta be careful with what I share here. There's a link on your test and quizzes folder that says Kahoot midterm review. If I'm a betting person, and we're in Vegas, so we are betting people, what do you think about that Kahoot midterm review? Have I ever led you astray with my reviews?
Nope.
So if I'm a betting person, I would look at that review. Trying to wink at you.
Mr. McKeever?
Yep.
I saw that there's a Therex review quiz thingy.
Yep.
When is that due?
Let me take a look when I have that due, because I forget off the top of my head. That is a really good question. I think it's by midterm, but I can move it if I need to. Again, it's my class. I can do what I want. I can do what I want. That's 205. PTA 205. I think I have it due like in mid of this month or something. 21. Course content. And that was just kind of a review of the first part of it. I have that. Why do I not have the date that it's due on there? I got to open the midterm review for Therex too. Make available. There we go. So both midterm reviews are available now. Wrong part of it. I have that one due. Oh, well, I have no due date on that. That was good. Thanks for finding something I didn't do. So I have no due date on that right now. So let me look at the calendar real quick. Let's just, so I have the midterm that opens next week. So let's just say, because the midterm will be, so I'll open it on Monday and it'll give you till the 21st to get done. So you'll have a full week to do the midterm, the two midterms. And we'll say it's due the following Thursday, so the 24th. So give you about another couple days to finish it. So you have plenty of time. I don't have any date on it. So we'll say 6/24 those quizzes are due. I didn't put a date on it. That's my fault. I'm a bad teacher. I'm the worst teacher in the world. Let me go in and just add that real quick for you guys. 6/24. There we go. I made them both due on 6/24. Makes it easy for you. All right. Yeah, so midterm